This is Run the List, a new show type from Blood and Cancer. In Run the List, we'll bring you the latest in hematology and oncology news from MDedge and Medscape. The stories in the show have been adapted for podcasts and are available in written form on either MDedge and or Medscape. The show notes include links to the stories, the original source material like journal articles, and relevant biographical information. I'm the voice of MDedge Podcasts, Nick Andrews. Today on the show, drug-to-drug interactions that you should avoid in patients with GI cancer, circulating tumor DNA clearance tracks with progression-free survival in non-small cell lung cancer subtypes, and an update on COVID-19 symptom duration. If you like the news and information Blood and Cancer show, let us know by leaving us a review in Apple Podcasts or by emailing us at podcasts@mdedge.com. Our top story today, MRI identifies significant prostate cancer. Prostate cancers that are missed on multiparametric MRI are small and not life-threatening, according to a new analysis of data that was published online in European Urology. You can find a link to the publication in the show notes. The study is called PROMISE, which stands for Prostate MRI Imaging Study. In the study, researchers enrolled 576 participants who underwent a multiparametric MRI scan, transsectional ultrasonography guided biopsy, and a template prostate mapping biopsy. In previous data from the PROMISE study, MRI showed 93% sensitivity for clinically significant cancer, while ultrasonography showed only a 48% sensitivity. The researchers concluded that the use of MRI as a first-line diagnostic tool could prevent 27% of all biopsies. However, at that time, researchers did not investigate the severity of the 7% of cancers that the MRI missed. For this reason, the researchers performed a post-hoc analysis which looked at the clinical significance of the cancers in question. Cancers met the strict definition of clinically significant if they had a Gleason score of at least 4+3 for tumor of any length, or if they had a maximum cancer core length greater than 6 millimeters for a cancer of any grade. Cancers met the less strict definition if they had a Gleason score of at least 3+4 for a tumor of any length or a max core length greater than 4 millimeters for a cancer of any grade. In the analysis, researchers found that overall Gleason scores were significantly lower for the 17 strictly defined cancers that were missed by MRI than were for the cancers that were detected by MRI. This was true when analyzing maximum Gleason scores as well. The median maximum cancer core length was 5 millimeters for the 17 cancers that were missed by MRI, but the median was 8 millimeters for the 119 tumors that MRI detected. MRI also detected every single tumor that had an overall Gleason score greater than 3+4 or a max Gleason score greater than 4+3. The researchers also assessed prostate-specific antigen or PSA density. They report that when they applied threshold PSA density to men who had a normal-looking MRI scan, they could reduce the proportion of missed significant cancer to just 5%. And when it's not possible to avoid polypharmacy, clinicians need to be on the lookout for potentially dangerous drug combinations. Dr. Rachel Reichelman is a physician with AC Carmego Cancer Center in Sao Paulo, and she spoke about this in a keynote address at the 2020 ESMO Congress on Gastrointestinal Cancer Virtual Experience. Dr. Reichelman pointed out one particular combination that can have deleterious effects on patients with GI cancers. That interaction is between proton pump inhibitors like omeprazole and chemotherapy regimens that contain capecitabine. She cited data that showed that the use of proton pump inhibitors can increase the risk for progression of colon cancer patients who are also receiving adjunct Capox or Folfox. The LOGIC trial showed that PPIs have a significant effect on both progression-free survival and overall survival in patients with HER2-positive gastric cancer who are receiving Capox either with or without lapatinib. Previous studies, including many from Dr. Reichelman's group, have indicated that potential drug-drug interactions occur in about 2/3 of patients and in approximately 1/3 of outpatients. One study suggested that 4% of oncology deaths in hospital were due to adverse drug reactions and interactions, while another study suggested that 2% of non-elective hospitalizations among oncology patients were for drug interactions. Dr. Benedict Westphalen is coordinator of molecular biology at the University of Munich Comprehensive Cancer Center in Germany. On Twitter, he added his own checklist of things to consider regarding drug-drug interactions. Some of the checklist items included were changes in drug levels, the effect on the microbiome, and differences in sex. Dr. Reichelman noted that the frequency of clinically relevant drug interactions in oncology patients who are enrolled in trials is not high at between 3% and 17%. She pointed out that this should be zero, however, because all clinical trials have a list of combos that should not be prescribed and drugs that should be avoided. In her conclusion, Dr. Reichelman made a series of recommendations for avoiding dangerous drug-drug interactions in cancer patients, the first of which is to avoid polypharmacy in the first place. She also suggested that high-risk patients, such as those taking many drugs and who have comorbid illness, should be screened for potential drug interactions, and attention should be paid to dangerous combinations. Combinations to avoid are those of two drugs that each prolong the QT interval. Those include quinolones, azithromycin, and clarithromycin. And clearance of circulating tumor DNA correlates with longer progression-free survival in patients with EGFR mutant MET-amplified non-small cell lung cancer who are treated with EGFR and MET-targeted therapies. This is according to an analysis from the Phase 1b TATAN study presented at the 2020 annual virtual AACR meeting. The median progression-free survival was 9.1 months for patients with circulating tumor DNA clearance, and it was 3.9 months for patients without DNA clearance, 3 to 4 cycles after starting treatment, osimertinib and savolitinib. Interim results of the TATAN study were published earlier this year in The Lancet. You can find a link to that publication in the show notes. The trial enrolled patients who had locally advanced or metastatic EGFR mutant MET-amplified non-small cell lung cancer who had progressed on prior EGFR TKI. The results included patients who were enrolled in Part B and Part D of the trial. Part B consisted of patients who had previously received a third-generation EGFR TKI and patients who had not received a third-generation EGFR TKI and were either MET-negative or MET-positive. There were 144 patients in Part B, all of whom received oral osimertinib, and 138 of whom received savolitinib daily. Part D included 42 patients who had not received a third-generation EGFR TKI and were MET-negative. Part D patients received oral osimertinib and savolitinib daily. Patients who were in the TATAN study had ctDNA samples collected at various time points from baseline through cycle 5 of treatment and until disease progression. The analysis focused on ctDNA changes from baseline to day 1 of the third or the fourth cycle. The objective response rate was 48% in Part B and 64% in Part D. The median progression-free survival was 7.6 months in Part B and 9.1 months in Part D. Among 34 evaluable patients in Part B who received savolitinib, 22 of these patients had ctDNA clearance and 12 did not. Among 16 patients who could be evaluated in Part D, 13 had ctDNA clearance and 3 had not. The authors noted that they needed to work on standardizing diagnostic definition of MET dependence, recognizing that loose definitions and polyassay use make data challenging to interpret. And finally today, a COVID update. Symptoms can linger for months. Clinicians and researchers have focused on the acute phase of COVID-19 infection, but it's increasingly clear that some recovered patients discharged from acute care need continued monitoring for long-lasting effects. This comes from a research letter that was published online in JAMA. The letter was authored by Dr. Angelo Carfi and his colleagues from the Gemelli Against COVID-19 Post-Acute Care Study Group, which is in Rome. You can read the original letter by clicking the link in the podcast notes. In the letter, the authors note that more than 87% of 143 previously hospitalized patients had at least one persistent symptom for 2 months or longer after initial onset, and at more than a month after discharge. Post-discharge assessments of patients who met criteria for SARS-CoV-2 negativity included a reverse transcriptase polymerase chain reaction test were conducted from April 21 to May 29th. Among the results, the researchers found that only 12.6% of the 143 patients were completely free of any COVID-19 symptom. About 32% of patients had 1 or 2 symptoms, and 55% had 3 or more. None had fever or other signs and symptoms of acute illness. About 53% of patients still had fatigue, 43% had dyspnea, 27% had joint pain, and 21% had chest pain. About 44% reported worsened quality of life in the EuroQoL visual analog scale. The average age was about 56 years old, and about 2/3 of the patients were men. The average length of hospital stay was about 2 weeks. During hospitalization, more than 72% of patients showed evidence of interstitial pneumonia. The reality of lingering symptoms has led Dr. Carfy's clinic to schedule a final wrap-up visit for patients after full assessment. In North America, docs are also addressing the reality that the road to recovery can be a long and upward one, with persistent symptoms worse than those seen with acute influenza. In an interview, Dr. Zaijian Chen, an endocrinologist at Mount Sinai in New York, said that persistent symptoms are much worse for COVID than for flu. He said that even flu patients who spent time in the ICU recover fully, and that we can optimize their breathing before they're discharged. The Mount Sinai program provides specialized interdisciplinary management that may include CT scans, endoscopy, and drugs such as respiratory medications and anticoagulants. The Mount Sinai program also offers training to combat the fatigue and deconditioning caused by the infection, symptoms that are not medically treatable but do impact quality of life. And that's it for hematology and oncology news for the week of July 20th, 2020. Blood and Cancer is produced by MDedge editor Jennifer Smith. Run the List is produced by Mark Lesney and Jennifer Smith. All MDedge podcasts are produced by MDedge executive editor Kathy Skarbeck and Medscape vice president Dr. Ivan Aransky. Today's stories were originally published online in July on either MDedge or Medscape. They were written by Ingrid Hine, Liam Davenport, Andrew Bowser, and Diana Swift. Blood and Cancer social media is produced by Kyla Clark. I write, edit, produce, and host the show. I'm Nick Andrews, and this is Blood and Cancer.